in this lecture, I am going to talk about chloramphenicol, the mechanism of action, key pharmacokinetic features, clinical uses and adverse effects of chloramphenicol. So how does chloramphenicol act? Chloramphenicol is primarily a bacteriostatic agent, and at higher concentration it can also exert cidal action on certain bacteria. So now let's see, how does chloramphenicol act? Chloramphenicol acts by inhibiting bacterial protein synthesis in the ribosome. Now the ribosome consists of two subunits, the 30S subunit and the 50S subunit. Now the messenger RNA complex gets attached to the 30S ribosomal complex and initiates the protein synthesis and exposes the codon for amino acid attachment. Now the 50S subunit consists of a peptidyl side or P side to which a nascent peptide chain gets attached. And there is another side, that is acceptor side, to which a new amino acid gets attached, and this is transported with the help of a transfer RNA. Now subsequently the nascent peptide chain gets transferred from the peptidyl side to the acceptor side, and there is peptide bond formation. So peptide bond formation occurs between the new amino acid and the nascent peptide chain, and this leads to growth and elongation of the peptide chain. Now once the peptide chain is grown, it is elongated, it is shifted back from the A side to the P side, and further protein synthesis continues. So these are the different steps of bacterial protein synthesis. So at which stage does chloramphenicol act? Chloramphenicol binds to the 50S subunit and prevents or interferes with the transfer of the peptide chain from the P side to the acceptor side. So this inhibits the peptide bond formation, the growth of peptide chain is blocked, and this inhibits the protein synthesis and multiplication of bacteria. So what are the key pharmacokinetic features of chloramphenicol? When it comes to absorption, chloramphenicol is rapidly and completely absorbed in the intestinal tract. Therefore, the commonest route of absorption is oral. When it comes to distribution, chloramphenicol has a high volume of distribution. It has high tissue penetration. It can penetrate into the serous cavities, into the peritoneal cavities. It can cross the blood-brain barrier and reach the cerebrospinal fluid. Therefore, chloramphenicol can also be used for the treatment of meningitis. So meningitis can be treated by chloramphenicol because it attains high concentration in the cerebrospinal fluid. When it comes to metabolism and excretion, chloramphenicol undergoes conjugation in presence of an enzyme known as glucuronide transferase enzyme with the help of glucuronic acid. So chloramphenicol conjugates with glucuronic acid to form chloramphenicol glucuronide. So this glucuronide metabolite is partly eliminated in bile, but majority of the metabolite is excreted in urine through the kidney. So in liver disease such as cirrhosis or in neonates where the glucuronide transferase activity is reduced, so in such situations the metabolism is reduced. So this leads to high concentration of the drug in the plasma, leading to toxicity, and this requires dose reduction. So before we discuss the clinical uses of chloramphenicol, it is important to know the antibacterial spectrum of chloramphenicol. Chloramphenicol is primarily a bacteriostatic agent, which means that it inhibits the growth and multiplication of bacteria. However, at high concentration, it can exert cidal effect, and this cidal effect is exerted on bacteria such as H. influenzae and Neisseria meningitidis. These are the causative agents for meningitis in children and young adults respectively. Now chloramphenicol, similar to tetracycline, has a broad spectrum action, which means that it is effective against gram-positive bacteria, gram-negative bacteria and anaerobic organisms such as Bacteroides fragilis. An example of gram-positive organism is Streptococcus pneumoniae. It is highly active against gram-negative organisms. It is more active than tetracycline against gram-negative organisms such as H. influenzae, Neisseria meningitidis, Bordetella pertussis, which causes whooping cough, Klebsiella, Salmonella type C, which causes typhoid fever, fever or enteric fever. Also, it is effective against anaerobic organisms such as Bacteroides fragilis. But to be noted that, like tetracycline, it is not effective against Pseudomonas, Proteus, and Mycobacteria. So, Pseudomonas, Proteus, and Mycobacteria are not affected by chloramphenicol. So now that we know the antibacterial spectrum, let's discuss the clinical uses of chloramphenicol. Chloramphenicol is highly effective in bacterial meningitis, which is also known as pyogenic meningitis. The causative organisms are H. influenzae, a cause of meningitis in children, Neisseria meningitis, which causes meningitis in young adults, Streptococcus pneumoniae, which also causes meningitis, and Listeria, a common cause of meningitis in immunocompromised patients and neonates and elderly. The first line drug for the management of bacterial meningitis is a third generation cephalosporin, which consists of ceftriaxone and cefotaxime. Ceftriaxone and cefotaxime attains high concentration in the cerebrospinal fluid and therefore effective in meningitis. Also, it has bactericidal action, and cidal action is crucial for treating severe infections like meningitis. And thirdly, ceftriaxone is highly active against gram-negative organisms, namely H. influenzae and Neisseria meningitidis. So, to cover the resistant gram-positive organisms such as Streptococcus pneumoniae, it is sometimes combined with vancomycin. So, ceftriaxone is combined with ampicillin to treat meningitis due to listeria, because listeria is highly sensitive to penicillin. So, combination of ceftriaxone and ampicillin increases the effectiveness against listeria meningitis. So now, what is the role of chloramphenicol in the management of bacterial meningitis? Chloramphenicol is the second line drug to ceftriaxone in treating bacterial meningitis. When the other drugs do not respond, the patient is intolerable to these drugs, chloramphenicol can be used as an alternative drug. Chloramphenicol is highly active against Bacteroides fragilis, and therefore it can be useful for the treatment of anaerobic infections such as intra-abdominal infections, pelvic abscess and brain abscess. Now, since chloramphenicol has high tissue penetration property, it can cross the blood-brain barrier. It is useful for treating brain abscess. Also, it can enter into the intra-abdominal sites and reach the necrotic tissues in the abscess where the anaerobic organisms thrive. So, because of high tissue penetration property and its effectiveness against Bacteroides fragilis, it is useful for treating anaerobic infections. However, the preferred antibiotic for treating anaerobic infections is metronidazole and clindamycin. So, metronidazole and clindamycin are the two antibiotics that are preferred in the management of anaerobic infections. However, to be kept in mind that these infections are polymicrobial infections or mixed infections. That is, although the anaerobic organisms form an important component, but gram-positive, gram-negative organisms also play a role. So, for broader coverage, these antibiotics are combined with penicillin or cephalosporin for action against gram-positive and gram-negative bacteria. The next clinical use of chloramphenicol is enteric fever or typhoid fever, and it is caused by Salmonella typhi. So, chloramphenicol is highly active against Salmonella typhi, which is a gram-negative organism. Now, till 1980s, chloramphenicol was the drug of choice. It was extensively and indiscriminately used because it is cheap, widely available, orally active. But gradually, resistant strains of Salmonella typhi emerged and the resistance spread globally. Because of the emergence of resistance, and since resistance of Salmonella typhi is a concern, other antibiotics were used for typhoid fever, and the other antibiotics are ampicillin and cotrimoxazole. So, ampicillin and cotrimoxazole are the other antibiotics that can be used in typhoid fever. However, for the management of multi-drug resistant typhoid fever, ceftriaxone, which is a third generation cephalosporin, is the drug of choice for the management of multi-drug resistant Salmonella typhi infections. But if the local strain is sensitive to chloramphenicol can be used for treatment. Now the next clinical use of chloramphenicol is intraocular infections. Chloramphenicol when administered systemically attains a high concentration in the intraocular fluid. Because of high concentration in the ocular fluid, it is useful for treating endophthalmitis, an infective condition of the eye, and because chloramphenicol is highly active against gram-negative bacteria, it treats endophthalmitis and it attains high concentration in the ocular fluid. Because chloramphenicol has high tissue penetration property, it can penetrate the conjunctiva. It is useful for treating conjunctivitis and external ear infections. They are available as topical preparations to be applied to the eye and ear for treating conjunctivitis and ear infections. Now in my last lecture you had learned that tetracycline is highly effective for treating brucellosis and rickettsial infections. So chloramphenicol is a second choice drug to tetracycline because tetracyclines are contraindicated in pregnancy and children, and where tetracyclines are contraindicated, chloramphenicol can be used as an alternative to tetracycline in the management of brucellosis, rickettsial infections. Also, chloramphenicol is highly active against Bordetella pertussis, a positive organism for whooping cough. So it is used as an alternative to erythromycin in the treatment of whooping cough. Now speaking of the adverse effects of chloramphenicol, chloramphenicol can cause bone marrow depression which can occur in two forms, that is non-dose related bone marrow suppression which can cause aplastic anemia, agranulocytosis, thrombocytopenia. Now this reaction can occur at normal therapeutic doses of chloramphenicol. Probably there is a genetic basis to it, and since this reaction is an idiosyncratic reaction, it is unpredictable and can be serious fatal reaction, and probably there is a genetic basis to it. Now the bone marrow depression can also occur at higher doses and prolonged treatment, and this occurs because of direct toxic action on the bone marrow cells leading to decreased platelet and bleeding manifestation. Reduction in the WBC count can lead to infections. So these are some of the manifestations of direct toxic effect of high doses of chloramphenicol or prolonged therapy with chloramphenicol leading to bone marrow suppression, and this is due to inhibition of mitochondrial enzyme synthesis. Due to inhibition of mitochondrial enzyme synthesis, the blood cell formation is inhibited and this leads to suppression of bone marrow. So the next serious consequence of chloramphenicol is grey baby syndrome. This occurs in presence of high doses of chloramphenicol in premature infants and neonates. So high doses of chloramphenicol in neonates or premature infants can cause grey baby syndrome. This is because the liver is immature, there is decreased glucuronide transferase enzyme activity. Because there is decreased glucuronide transferase enzyme activity, the electron transport chain is blocked, there is decreased glucuronidation, conjugation and metabolism of chloramphenicol leading to high doses, leading to toxic levels, and high doses of chloramphenicol can cause blockade of the electron transport chain in the liver, in the myocardium and in the skeletal muscle. So what are the manifestations of grey baby syndrome? It manifests as GI side effects. The baby stops feeding, there is vomiting, the abdomen appears distended, and also there is passage of green stool. There can be hypotonia where the muscles become flaccid, the baby becomes lethargic. There can be reduced circulation leading to cold peripheral extremities, low body temperature, hypothermia can occur, blue lips, grey skin or cyanosis leading to circulatory collapse, irregular respiration and death of the baby. So in neonates, chloramphenicol should be avoided, and if used, it is used in doses less than 25 mg per kilogram. Now the other side effects that are possible with chloramphenicol use are hypersensitivity reactions such as rashes, angioedema which is infrequent. Also drug interaction is a possibility with chloramphenicol use. So chloramphenicol is an inhibitor of metabolic enzymes. It inhibits cytochrome P450 enzymes that is responsible for metabolism of other drugs such as tolbutamide, warfarin and phenytoin. So because of inhibition of these enzymes, the drugs accumulate in the plasma leading to toxicity. So increased accumulation of tolbutamide can cause hypoglycemic episodes. Increased accumulation of warfarin can cause bleeding episodes. Accumulation of phenytoin can lead to toxic side effects. So because chloramphenicol is an inhibitor of cytochrome P450 enzymes, inhibition of enzymes leads to accumulation of the drugs and leading to toxic side effects. Also, the metabolism of chloramphenicol can be induced with drugs such as phenobarbital, phenytoin and rifampicin because these are inducers of metabolic enzymes. They enhance the metabolism of chloramphenicol leading to therapeutic failure. So therapeutic failure can occur because of increased metabolism of chloramphenicol, and toxicity can occur because of chloramphenicol acting as an inhibitor of metabolic enzymes leading to toxicities. So with this we come to the end of this video. Thank you for watching. If you find this video useful, please like and subscribe to this channel.